Hey guys, this is a video mainly for clinicians out there, and I'm going to go over a case study which I thought was a very interesting one, and it actually is more common than you think. I had a baseball player presented here, a high school athlete, who first described tingling in the fingers. First thing we have to consider with this is the possibility there's some type of nerve entrapment somewhere. Is it the neck, the brachial plexus? Is it around the shoulder? Is it around the elbow? Is it around the fingers? Who knows? So we have to make sure to check. However, what we did find was that he had a correlated shoulder condition. And what we found during the exam revealed how we're going to treat him. He, in this case, was going to be more of a stabilization case more so than a manual therapy case. He's going to respond to both, but in the exam you're going to see that it was actually very surprising what triggered his pain, what his switches were. Enjoy. Okay guys, we're going to go a little bit into theory here of why this person is having their pain. Okay, so from the troubleshooting process, this finger numbness or this ulnar nerve types of distribution can be from a couple different things. We have to assume that if there's a change of sensation, that the injury is to a nerve somewhere. And I'm not saying an injury as in regards to it's torn or pinched or crushed or so on, but it's probably pressurized. It's affected in somehow, some way. We just got to find out where and what changes that load on it. Now, when I grab this is just generally speaking here, and this is how I would explain it to a patient, is that look, you got this long nerve here, okay? It could be affected up high, it could be affected midway, it could be at the elbow, it could be at the hand, it could be a lot of places. Heck, if we put a tourniquet around this right here, this would affect it too, right? It's somewhere. But one thing's for sure is that if there's loss of sensation or change of sensation, it's a nerve somewhere, okay? So if it's just these digits right here, we're looking at probably the ulnar nerve, or we're looking at a couple different nerve roots. I never typically go over nerve roots with patients because it confuses them a little bit. Usually, generally speaking, you speak about larger nerve or collections of nerves, they tend to get it better. But that's typically your choice. Okay. So this person in particular, what we found was that number one, this nerve bundle goes right here. It goes by the shoulder. And this person being a pitcher, what we found was that this right here was worse when he was sleeping. So he's back here and let's go right here. And he's got his arm over his head when he's sleeping. It was on the throwing side though. So what happens is it's this externally rotated position, which is also very similar to throwing late cocking stage, all right? So my theory was that, well, there's a shoulder aspect to his injury. By the way, do you have shoulder pain? Why, yes, I do. Okay, where is it? Well, it's back here, and it's down here. So what this tells me is that we're looking at the possibility of having some type of instability in the shoulder, and here's the reasons why. Okay, and I won't go over into all the exam findings because it's going to be too long of a video. But the bicep comes down, so if they have biceps pain, you have to assume there's half the time there's a possibility that there's the labrum involved. The labrum is a cartilage ring, it's an O-ring or a gasket, as I like to say, that deepens the ball and saucer of the joint. The shoulder joint or the glenohumeral joint in general is a very unstable joint because of the amount of movement that we have. But you got to have some stabilization, it falls out and it affects the stuff around it, which in this case is what I believe is happening. So the biceps tendon creates pain, and there's pain back into here, which is right around the area where I would consider the labrum to be slightly affected. Whether it's a grade 1, grade 2, grade 3, or so on, whole different story. I believe it to be a lower grade 1 and a non-surgical one at this point, but that is a whole different story for a different time. But when we're talking about this numbness into the pinky finger, we have to consider the possibility that if this person has a labrum issue, there's also the possibility that is a unstable joint relatively to what it normally is. And a lot of times what happens in this position, which is really not favorable to stabilization of the shoulder, is this shoulder part right here, the humeral head moves forward, which can pressurize on this bundle. Now, dynamic testing of this. You can take them in this position, say, how does that feel, and try to stabilize them in a couple different ways. Number one is you can manually press them in. It's almost like an apprehension and relocation sign. It might decrease this. Second is you can use trunk stabilization to accommodate this. You can have them brace or fingers into the sides, which I do, and I say force my hands out with your belly contents. So they push out, which then helps out with lower level stabilization. Or there's a possibility that they're extending their spine here, which then will affect some of the upper level articulations, or what I call the dynamic strut of the shoulder. We have the strut here, which is the clavicle, which is the strut which doesn't move a ton, it does move a little, but let's just say it's a fixed strut. And then we have the dynamic strut, which is the shoulder blade, the scapulothoracic joint. Now, what I like to do with this as well is you keep him exactly in the position of pain, up high, and you can bring them low into changes of position to see if this affects it. All right, you might have to hold him into this position. Or, in this case, I actually had him on his back, and I said, how's that feel? And he was on the table, and he said, yeah, that's tingly. And I said, cool, let's bring these knees up. How's that feel? He said, the same. I said, how about this? And he said, oh, it went away. I said, okay, so let's bring this down again. Let's wait for that. Just relax the belly there, okay? All right, 30 seconds later, he said it came back. So I said, okay, lift those up again. Bring the feet up. How's that feel? Oh, it's going away. So what this tells me is that the spine lower is an issue. It's not broken, it's just not doing its job to stabilize the upper components. Because here's what we know about baseball throwing. And by the way, this goes along the same thing with other people having daily routines of putting things overhead, throwing babies in the air, whatever it might be. It doesn't matter. The mechanics of the body are the same. It's just different levels of performance. Okay? What we know about baseball is that a strong majority of the throw comes from the hips, okay, and the legs and the torso, and a minor percent comes from the shoulder. I think the rough estimation is under 20% comes from the actual shoulder itself. So if that shoulder is getting unstable, we have to look at the lower components as well. So the corrections that I asked this kid to do were based upon two things. Number one is we look to see if we can stabilize the shoulder girdle, just as a test. Second was that I looked to see if we can stabilize and create higher intra-abdominal pressure within the belly region here while moving the shoulder into a compromised position. That might be confusing, but it can be as simple as this. You can use a post or something of that nature. You can put them into a kneeling position right here. Put them into a throwing position right here. All right? Ask them, when does it come back? Right? And I'm not even going to use this pole yet. And he says, okay, it came back. I said, don't change this at all. I want you to force into the wall. Or even punch into the wall here. Oh, it went away. All right? So what we're doing is we're practicing getting into the position without going through movement and stabilizing the torso. Because these people can't be slack the entire time. Baseball players live in extension, but at the same time you can't be passive extension. You have to have some pressure in there to allow it to safely occur. Now, in case you're wondering, why am I doing this arm drive? Go ahead and try it yourself. All right? This is just a way to trick the abdominal wall to work. It has nothing to do with the hand. You can do the same tricks with other parts of the body too. But I always tell people, hey, look, go ahead and stay right here. I stand in front of them, and like say my hand is the pole. I said, look, I'll give you $1 if you can push me away without using your core muscles. So I just forced into them real hard, and they drive, and I said, does your core turn on? Why, yes, it does. To have proper shoulder function with throwing, to protect that nerve bundle from getting pressurized as it passes by, you need to have proper trunk stabilization. And this is why I'm not a big fan of the sleeper stretch. This is the reason why I don't like a lot of passive stabilization, and I don't like people talking to each other when they're doing stuff like this, okay? Pay attention. If you're injured, you probably got an issue with software. All right, your programming of movement is probably not amazing. Let's spend time, drill it in, go through that movement if you want to. Once you've mastered it, kind of like driving a car, stick shift, you can start eating ice cream afterwards, but don't try to eat ice cream when you're learning, all right? This is one of the exercises I chose for him to centralize the ball socket as well as create tension in the abdominal wall. Now bringing the spine up to the height of the shoulder blades and then tenting the rest of the body. This is one of the exercises we learned in DNS. Now the reason why I chose it is because if this person's having issues with the late cocking phase or having the arm back behind the body, this is actually a great way to train that within a roughly isometric contraction, or at least a small movement of it. So I'm focusing on getting my abdominal area to be engaged as well as having high internal pressure as my arm is in this more compromised position. Next we're going to go into an exercise called the kettlebell arm bar, which is helpful, again, moving the torso and keeping the arm fixed, which is what happens with throwing. So bring your arm across here, one foot down, one heel down, drive the weight into the air. If you have shoulder pain with that, you start on the side here. Sorry, I'm on my mic. We're going to roll this way, double hand drive into the air, and then leave it steady. You're going to notice that the hand, if it's over the shoulder, it's perfectly fine. When you start wobbling around, that's where we run into problems. Okay? So you're going to drive this straight into the air and let it lead you to your left shoulder. Okay? My toes still on the ground here, and I'm log rolling all the way to my side so my hip pocket is facing the ceiling. Bring the toe across, get real long, keep looking at the weight. Notice I'm not extending too far and I'm not rounding. You want to make sure you breathe and create pressure within this area right here. Slow return with the foot first. Get halfway, put the pocket against the ceiling. Roll all the way back and down. Keep driving, 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 driving. This, I hope, was a useful case to you. I know I don't have a model on this one, but at the same time, I'm doing the best I can for like this. I did get a couple chiropractic students who said that they would like to see more case studies, so I'm doing this purely for you guys. And if you guys ever want to take a spurt through the clinic here, by all means, hit me up. If I have patients that are going to be nice to examine that day, by all means, I'd love to show you guys.